Well, a lot of them are like, I don't know what's happening to me. I'm so forgetful. I'm so irritable. I feel, I can't sleep at night. Mood swings. I'm gaining weight. I mean, there's no one size fits all for all women.
6 million Canadians don't have access to primary caregivers. What does hormone therapy look like for them?
It is very important that patients understand why they're being offered treatment options. And a lot of people have acquired medical degrees off the internet.
I'm Dr. Beatrice Seguin, PhD, and you've landed on my podcast this time of the month, your trusty sidekick to the midlife roller coaster. I chat with experts digging into legit solutions for midlife hurdles, be it health or lifestyle. Ready for the ride? Dive into this time of the month. Subscribe and catch the latest episodes on our channel. Let's own this midlife magic together. According to the Menopause Foundation of Canada, 46% of women feel unprepared for this stage of life we call perimenopause and menopause. 54% believe menopause is still a taboo subject. I was one of those women. I was blindsided by menopause, and this journey has ultimately led me to share my experience with you all because I don't want anyone else to feel unprepared, blindsided, or dismissed. I've always felt it's really important to connect with people in our communities who are providing care in our Canadian context at the front line. You're going to see a lot of things on social media, but the reality is we live where we live. And so let's talk about practical things that we can do and learn surrounding our menopause health. Today, I have Dr. Fola Sam-Ogunbiyi, a family physician with 18 years of global experience. She has lived and practiced in Nigeria, the UK, and Canada. So, Dr. Fola, welcome to the couch.
Thank you for having me.
I'm so excited that you're here. I'm curious what you think of these statistics I just read. Do you see that mirrored in your practice?
Yes, certainly. I see that quite a lot. Lots of women struggling with menopausal symptoms, not sure what's happening, and having no one really to talk to. Some of them do, raise it up in the consultations, and I can, educate them as to what's happening. But yes, the statistics do show what I see in my practice as well.
So they don't come to you saying, I'm menopausal. Is it more, what do they come, what's the complaint they'll come with?
Well, a lot of them are like, I don't know what's happening to me. I'm so forgetful. I'm so irritable. I feel, I can't sleep at night. I'm just so upset with everybody. Mood swings. I'm gaining weight. My body is out of control. And then I ask, how have your periods been? And then they can't even remember when they had a period last, many times. And some are like, yes, my periods have been, irregular, and I used to be regular. And then that leads us to the, down the road of maybe you are, having that change of lifetime. And those symptoms are just signs that, you're going through the menopause.
How do you manage that in what is typically is it correct, a 7 to 8 minute interaction? Is that a true statistic?
7 to 8 minutes?
Yeah. Tell us, what is it like for you in your practice?
Well, it's quite variable. 7 to 8 minutes could just be someone who wants a sick note. They're better and they just need to get to work.
Yeah.
That hardly ever happens. Most of my consults last longer than that. And just because people have so many things they want to talk about. They never come with just one thing. Mm-hmm. And oftentimes you just have to filter through exactly what's most important to get that out of the way first. And then you get on to the other things. But yeah, typically if you were talking to a woman about menopause, it would be a lot more than 7 to 8 minutes.
Yeah, it's definitely a complex issue. Have you observed differences in the fact that you've practiced in different settings? How do women perceive their menopausal journey, and how is the practice managing those symptoms vary?
The perception of menopause is very variable. Mm-hmm. And like you said in the intro, I have practiced and lived in 3 continents. I'm Nigerian. I had my medical degree from Nigeria and did a bit of family practice before moving to the United Kingdom for my family medicine training. And while working in Nigeria, we did have patients, who were going through the menopause, but they would hardly ever complain. They would rather talk to their mum, a friend, a neighbor, an aunt, and even when they brought it up in consults or, you asked about it, they didn't expect any help. Most times they didn't get any help. It was just considered part of life. Just get on with it. But then in the UK, it was slightly different. My experience just showed that a lot of women wanted to talk to somebody, a health professional, about what they were going through. And a lot of them would talk to me about, their symptoms, the hot flashes, the forgetfulness. And HRT was, widely talked about. And people wanted to know more, how safe it was. You're aware of the studies that happened that, put a damper on that. But things are coming back from that now, and a lot of women were interested in the UK. And the same in Canada, although slightly different. I find Canadian women are more interested in alternative, at least my experience, alternative ways of treating the menopause. Non-hormonal therapies.
Non-hormonal or non-medicinal? Or?
Yes.
So how do you manage that? Do you work with other healthcare professionals that are in the alternative medicine sphere?
I do have patients who also see naturopathic doctors, who see integrative medicine specialists, and I have nothing against it. I feel it's a complementary service. I feel we're all members of the health team, but I feel education is very important. Letting someone know exactly the science behind what you're offering, what are the pros and cons, and letting them make the decision that's right for them. And I always, tell patients, I'm not a naturopathic doctor. I'm not a specialist in that area. So when I get asked about different, portions and things, products, I'm like, I'm not trained in that. But there are people who are. And these are the questions you should ask them. What are the side effects of what you're offering me? What can I expect? What is in it? Those are things, and these are the other medications I'm taking. Are there any interactions? Just for your safety, so that when you agree to take, any prescription that is given by other, specialists, you know why you're taking it and you know what to expect. So I do a lot more of education, in my practice.
Do you find yourself educating women on their symptoms or more on the treatment options?
I find myself educating them on explaining why they're having the symptoms. A lot of them want to know why they're having hot flashes. What can they do to prevent them, and how they're not really preventable, just because it's, the thermoregulatory center in the brain there's very little that can control it. And so just explaining why they're feeling the way they are, why they're forgetful, So I find explaining their symptoms helps a lot of people to understand and accept what they're going through, and then explaining the treatment options to see which they would, like to go with.
We've talked about this on the podcast on several episodes, and I live in an echo chamber because I think of menopause all day long. Now that I'm dedicated to this project. But when I'm outside in the community having dinner with friends, girlfriends, any event, the question of, is this perimenopause, or is this just aging? I can't tell. Or is it something else? What can you tell us to help us navigate? Like, when should I be worried about something? When should I intervene or treat?
So the perimenopause is a stage of life between, before a woman's period starts.
Yeah.
It's called the climacteric as well. And after the period starts, the very last period. And that last period, no one knows when it's going to be. You just have to look in hindsight and then say, oh, okay, when was your last period? And as long as it's more than 12 months, then you can say, yes, you've had the menopause. But you don't know when it's going to be. And it could be 6 months before the period actually stops that you start to feel all the symptoms, the hot flashes, the not sleeping well at night, the weight gain. And so I always encourage women, when symptoms are persistent and when they're getting in the way of what you want to do, you should talk to someone about it. And usually, most people talk to their family doctors about, what this is becoming a problem. I'm dealing with this, taking off the sheets, covers at night. I'm not waking up refreshed. I'm forgetting things. So if it becomes repetitive, then you should talk to someone about it. And then your family doctor can walk you through, okay, so maybe you are perimenopausal, and then talk you through the options of managing that period in life.
I think what a lot of women struggle with is how long that period is before that last day, right, of your period. And the recurring theme is, it's so chaotic. I'm up, I'm down, And there's a sense of just being overwhelmed, and therefore, like, there's not much I can do but grin and bear it. Or there's a lot of misinformation. You know, a lot of people tell me, oh, do I have to wait to be menopausal to get treatment, right? So there's a lot of misconceptions. So are there things you'd want someone to know, like, hey, you know, if this is like a long period, yet there are things we can do. So how do you approach your patient who might be feeling that way?
Usually just encouraging them or educating them to know that what they're feeling is normal. It's not a sign of some terrible disease that's happening. And then to tell them that it's a dynamic thing, that it's unpredictable. But the important thing is, like I said, if you're having symptoms that are repetitive and are interfering with your functioning, then you should get help. And there's lots of help. So grin and bear it is no longer one of the prescriptions that we give. At one time, yes, many, many years ago, but that women should talk about, you know, and feel confident to be able to ask the questions from the health professional. And oftentimes, you know, but I find that a lot of women talk more to friends, talk more to family, check internet, Google stuff. Before they come. And so they come with an agenda, and they're like, you know, you have to spend time, first of all, you know, debunking all the theories and the myths and, you know, that they've come up with, and then trying to like offer them, you know, some credible information.
So what are some of the myths that you find yourself repeating to people, or debunking?
Oh, this is just good. This is short. My mom had it for 6 months, and so this is like 5.5 months. Mine should be over now. What's going on? You know?
The thought that menopause is just a short period.
Or I still had a period like 3 months ago. What's happening? You know, people struggle to understand, you know, that the periods can be delayed and then can come back. You know, you could not have anything. You may not have anything for 6 months, and then the period comes back, and you're like, oh, so I'm not menopausal anymore. You know, that's a very common one. Something terrible must be going on for me to be feeling this way. Maybe I'm getting dementia. That's a very common one.
I can identify to that one. The brain fog can be so powerful.
Yes.
That you're thinking, is this a precursor? Actually, is there any correlation? You know, is brain fog an indication of any future issues?
I'm not aware of
cognitive
any studies.
issues. Yeah.
I'm not aware of any studies that have linked, you know, the brain fog of menopause, because it's such a dynamic thing. It improves with dementia. Maybe there are. I'm not an expert, but I'm not aware of any studies. But that is something that a lot of women, you know, are really concerned about.
Because you're usually high performing, right? You're high performing, and all of a sudden you're forgetting stuff.
You know.
Is there anything we can do about the brain fog? What are some options?
Exercise is an incredible therapeutic, and I'm not sure of studies, but, you know, a lot of people say that, you know, when they exercise, drink a lot of water, it helps the brain fog on a regular basis, especially aerobic exercise, you know, where you get your heart racing. Doing that on a consistent basis tends to help a lot of people.
Is there, do you find that you encounter fear of taking medications, the concept that if I'm medicating to help with my perimenopausal, somehow I'm not managing it, or that I'm taking, you know, a non-natural remedy? Yeah.
That's a very common one as well. Lots of people shy away from, you know, hormone therapy or any kind of, you know, treatment for their menopausal symptoms, just because they say, well, if this is part of life, then I just want it all natural. I just want it, you know, I don't want any interventions. But then, you know, I just ask women, is it stopping you from doing, you know, what you would normally do? Is it having an impact on your life? And if it is it worth, you know, getting some help rather than... But it's a personal decision. Some women feel it's a badge that they have to wear, and you have to meet people where they are. People sometimes want help, and some people just want to talk about it and understand what's going on. And once they do, they're ready to, they don't want any interventions whatsoever. I've
noticed there's a lot of misunderstanding around the actual therapeutic options. So maybe we can talk a little bit about the different things. So you've touched on hormone therapy, but if someone doesn't want to, you know, engage in hormone therapy, there's a lot of fear attached to some of the medications that can help address certain symptoms. Do you want to tackle some of the most recommended treatments and walk us through the benefits and debunk the myths that may be attached to them. I think of antidepressants as an example because they're called antidepressants. So I'm not depressed, so why are you giving me this?
Right.
Yeah.
That's a very common one. And if you understand the antidepressants, they're used, not all antidepressants, they're just a class of antidepressants that have been found to be helpful in managing mainly the vasomotor symptoms, that's the hot flashes. Just because it's not because, you know, they're imagining the symptoms there. These symptoms are real, but they originate from the brain. And so these chemicals work on the thermoregulatory center in the brain. And that's why they also work for depression, but not at the same doses. And so I try and explain that to women that, yes, they work in a similar way, but you need it at a different dose. And the problem is that the regulatory center for temperature control in your body is also at the base of your brain. And so that's why these drugs work, you know, brilliantly for them.
That's really helpful because we feel hot flashes here, right?
Yeah.
Sort of the emanating
heat, yes.
Heat. We don't necessarily know that it's
coming from
here,
brain, yes.
And understanding that different doses, you know, of medication. So that's a good one to debunk. What are other medications where patients may be apprehensive to explore?
Well, there are, you know, some blood pressure medications really that can help. And usually if women are on other blood pressure medications, I always tell them we just have to keep a close eye on your blood pressure because it could drop it further. But there are some people who feel more comfortable with something like clonidine, for example, rather than an antidepressant, because of the stigma around antidepressants. They prefer this. But then if they're also on blood pressure medications, we have to make sure that their blood pressure doesn't drop too low. And so that's another common one that we use. And really, the emphasis in treating symptoms in menopause is not just a blanket treatment, but to treat what are the symptoms that are most disconcerting. For some women, it's just vaginal dryness. And so a local, you know, therapy is all they need. They don't have to take the full hormone therapy.
I don't know how many people know of this or are offered vaginal estrogen. Can you tell us the difference between the topical and what is found in the systemic, the hormone therapy that you take either by patch or orally? It's
the same, but it's the dosing and the fact that it's short-acting and it's local. So you don't have the full side effects. And so you don't then have the increased risks that are associated with taking systemic estrogen. And it just works locally just to help with vaginal dryness and reducing the frequency of urinary tract infections, which are the two commonest things that, you know, local problems that women with menopause tend to struggle with.
Vaginal dryness is a really interesting topic because I don't know that it's associated with younger women. Perimenopause can start quite early,
yes. Right?
We're not necessarily thinking it happens in our late 30s and 40s. Do you approach it proactively? Do you offer this to your patients? You tell them about it? How do we get the word out? Because I think a lot of people do not think it's a problem that happens early in life.
You mean the vaginal dryness? Yeah. Well, if a woman is describing symptoms of menopause, I ask all of other symptoms, even if she doesn't mention it. And oftentimes, women can be a bit reticent about mentioning that, but it is quite common, very common. And so when you ask, you know, upfront, is this a problem? And you get a positive answer, then we talk about why it's happening and what can be done. And a lot of them are like, no, I don't want any hormones. I'm like, well, it's locally acting hormones for you to try. It's not absorbed systemically in the whole body, and the risks associated with systemic absorption don't exist with it. And then oftentimes people are reassured to try it. Proactively, I only bring it up if a woman, for example, has had a hysterectomy when she's young for maybe treating endometriosis and things. So you expect, you know, or they've had some kind of pelvic surgery that can compromise their hormones, their ovaries.
Yes.
So then you expect that, you know, they may be approaching menopause sooner than expected. And the gynecologist who did the surgery has long discharged them, you know, they're back with me. So I ask upfront, you know, just to make sure that we catch it early. Because a lot of women are not expecting it, and, you know, if they're not aware, and especially if you're not at that age, they may not think it's a problem.
Is it okay to take vaginal estrogen and hormone therapy at the same time? Again, a lot of misconception around that, like, oh, I'm double dipping, so to speak.
Yes. Yes, some people do.
Yeah.
Oftentimes, if people are on systemic therapy, they tend not to need vaginal therapy, hormone therapy, but some people do, and they find it useful. And it's just a small dose, so it really doesn't make much of a difference.
And is it something you have to do every day, or?
Well, most prescriptions start off with, taking like 5 times a week. And then having like a break at the weekend for the first month. And then the maintenance dose is usually twice or 3 times a week.
One thing I've noticed recently with the movement in menopause is almost a fear of missing out on hormone therapy, and almost the reverse. Should I be on it? Should everybody be on it? Can you speak to that?
I mean, yes, there's the fear of missing out.
Yeah, the FOMO of hormone therapy.
Yeah, fear of missing out on almost anything. But hormone therapy is not for everyone. And I think people have to be comfortable. The most important thing, I think, with hormone therapy is understanding you. What are your personal risk factors? What are your symptoms? And then educating yourself as to what's available. So because all my friends are on hormone therapy doesn't mean I have to be. If my symptoms are just, vaginal dryness, then you can just have local ones. Or if I'm just having hot flashes, you can just go for, something that's non-hormone. And especially if you have increased risks like a family history or past medical history of breast cancer, or, a higher than average cardiovascular history. Those are things that, are particular to you. And so you may not want to, just join the bandwagon. And
yeah, because there's a lot of discussion about how, there are these added benefits, especially in a shorter window, like in the first 10 years
yes.
of menopause. In terms of bone health and other things. And I feel like, well, if a woman doesn't qualify, what should she be doing to make sure she's taking care and giving herself the chances to have those strong bones and those longer term chances of living a good life. Yeah.
There's lots that we can do, that women can do, just generally maintaining a good weight. Smoking cessation is very key. Watching alcohol intake, regular exercise, sleeping well, drinking lots of water. Those are things that, are in your control that can improve, life generally, because they translate to reduced cardiovascular risks. They translate to, stronger bones. Taking things like calcium, vitamin D, especially if there's been exposure to steroids in the past from asthma or any kind of condition like that can put you at risk of osteoporosis. So if you do those things, those are things that can help you, and you don't always have to go on hormone therapy, even though we know that the benefits for hormone therapy are better when you take them as soon as rather than later on.
You mentioned calcium and vitamin D. What is your take on supplements? Because there's a whole industry out there telling us we should be taking this or that supplement. How do you counsel your patients or help them navigate through that?
Well, I generally have a baseline rule. Eat healthy. 5 portions of fruits and vegetables every day. You will get most of what you need from that. But we do know that sometimes our diet is not as healthy as we would like it should be. And some people are at higher risks. So like for osteoporosis and women in menopause, they're encouraged to take calcium and vitamin D. And just generally in Canada, because there isn't much sun, there's vitamin D deficiency is very, very common. And people don't check their vitamin D. So they don't need, a lot of people go through life not knowing that they're deficient in vitamin D.
Is it a routine screening? Like, should we be screening for these things?
We should be. But interestingly, the government...
No, go there. Let's go there.
Because it's a pet peeve of mine. The government won't pay for it until you become deficient.
That just seems counterproductive, because by the time she's osteoporotic and getting a fracture, she's going to cost the healthcare system a lot.
Yes. But I don't know the thinking behind it, but you have to pay for vitamin D to get it checked. If it then comes back low, subsequent tests are free. But to actually screen people for vitamin D, It's not available in Ontario. I don't think that
So should we just be drinking vitamin D like there's no tomorrow? I'm joking. Please, viewer, don't do that. But I'm just saying, what can you do then if it's not part of the routine?
I think having a healthy diet,
Yeah.
trying to spend as much time in the sun as responsibly, possible, and then just take vitamin D supplements and, okay, usually most people are okay to check it at their physicals, and you don't have to check it every year.
Is it costly if we were gonna, you may not know this answer, but is it something that if you can do is worth doing? I guess that would be my question to you.
Oh, it is worth, definitely.
Yeah,
and it's only about $20 or so.
Okay.
It's not a lot of money.
So it might be worth it because we might be walking around
Yes, deficient in
with
vitamin
deficient
D.
in vitamin D.
Not knowing.
I'm curious about magnesium. I've heard a lot about magnesium. It'll help sleep. It'll help this or that. What's your take on the magnesium?
Magnesium is one of those supplements that's very useful for many things. It helps headaches, helps sleeps, leg cramps. I don't routinely check it just because the evidence is nebulous, but it's another supplement that people take. I don't recommend it. I don't regularly recommend it to people, but I have nothing against people taking magnesium.
So here's my question. If the evidence is nebulous, is it harmful to take like obviously food first, but let's say you take some magnesium supplements at night to help to try and get better sleep. It's not harmful.
It's not harmful, not in the least, and it does help sleep. It's been the studies have shown that it helps sleep. People who have chronic headaches, it helps them. Even leg cramps, at nighttime cramps, it helps.
So which part is the nebulous part then in terms of evidence?
People taking it to treat. It helps in that it's not in all situations, and they're not randomized controlled studies. So that's why we can't prescribe it.
Got it.
Like an antibiotic or something.
Okay, that's really a helpful clarification. Are there any? Is there anything you would want our viewer to know to say? You know what? There's really no. Maybe you want it, there's harm attached to certain practices or supplements.
Well, there are lots of supplements, and I wouldn't name them because I've had patients who've taken supplements that they've gotten on the internet that's crashed their blood pressure, dropped their sodiums. So there are things that can affect the electrolyte, balance in the body. And oftentimes these are things that people just get, not necessarily off the shelf, but, on the internet mainly. So I would be really wary of, buying stuff on the internet for menopause. I would say it's best to go into, if you wanted to go natural, go into a health food store, because then you have someone there who can tell you what's in it. And you're not just buying something from off the screen. So that's what I would say.
Sometimes we think something's natural, that it's not harmful, right? Are there situations where supplements can interact with other medications that we should be aware of?
Definitely. Yeah. There are lots of different supplements that have high electrolyte content, and they can affect things like your blood pressure. They can affect, your electrolyte composition. They can cause low sodium, different, and make people really sick. So that's why it's important that it's worth, if you're getting something that's prescribed by a naturopath, for them to let the person know what else you're taking. Most of the harm occurs when it interacts with other medications that you've been prescribed. Rarely does it happen that you're not taking anything, and sometimes it can, that you're just taking that natural supplement and it causes a problem. But usually it's an interaction with already prescribed medication.
So really do not shy away from sharing with all your care providers what you're taking.
Yes, that's the take home.
Yeah, that's the take home message.
Yes.
That's a good one. Dr. Fola, I want to go back to the fact that you've practiced in 3 countries. We talked a little bit about perceptions and the healthcare systems. If you could cherry pick what you've learned from these 3 countries, what would an ideal menopause care, perimenopause care program, if that could be called that, look like?
Well, that's a pretty tough one. But I think a combination of all 3. In that my African experience, which is this is part of life, this is a woman's journey, that enabling spirit that I can do this, if I could add that to the interest in getting help for fixing the symptoms and being open to accepting solutions that you see in Canada, even if they're not the typical straightforward take hormone therapy, I would say a combination of that would be ideal. So if you have a woman who understands that, yes, this is part of life, but I would like to get help. And then having the confidence and the boldness to ask the questions of her healthcare providers, what's available to help me manage the symptoms? And having the education to know what is best suited for her. I think that would be ideal.
When you were in the UK, because I'm not sure, in what time frame that was in, and they've certainly made a lot of progress, right? Even at the policy level in the UK for menopause care. Were there checklists? Is there such a thing? I mean, when I was pregnant, you go to the doctor, there's this whole series of things that it triggers, right? We want to make sure you're taken care of. We're going to do these things, that thing. Here's a book, what to expect. Then you kind of fall off, post-reproduction.
Yeah.
Where is that checklist? Do we need a checklist?
I think we do. We do have somewhat of some kind of a checklist in England as well as in Canada as well, because we have things like annual physicals that women, and depending on your age, there are things that you're supposed to be doing. There's cervical cancer screening, there's mammograms and things like that. And so when you go to your physical, those are things that are asked, and that they trigger other questions. Are you having periods? And if you're not having any periods, then are you having, hot flashes? Are you having, mood swings? Those are things that generally tend to be asked when you go for an annual checkup.
I'm going to put you on the spot, Dr. Fola. So don't take the rap for your entire profession. But I haven't heard a single person tell me that she was proactively asked these questions. So you might do that, but I don't think it's a common experience.
Well, I mean, I don't do it all the time, is the truth.
Yeah.
Because consultations can go, we have the ideal in our head, what we want to do. But then you could start off and then, she starts to talk about, how depressed she is, issues with the husband, issues with children, having to care for parents. And then you go down that rabbit hole and time is gone and you're like, oh, you're here. And then you just rush through. So we know the things that we're supposed to ask, but consultations are dynamic things. And so you don't always get through everything in it's easy for me to say, oh, we do this and do this and do that. But in real life, you have to go with the flow. Some women are just so fixed on something. And so you have to work to get them away from that to actually get through whatever checklist you have. So there's so many things that are happening. But generally, these are the guidelines that we're given to practice with. In the profession. And
Dr. Fola, I certainly wasn't trying to put, to put so much pressure and blame on doctors, but you're right, it's dynamic. So how do we take it to a place where it becomes more perhaps systematic? What I mean by that is there are certain screenings that automatically happen, or they're triggered, right, by your age. So yes. When I turned 50, I received this really nice envelope from our provincial ministry, the government, the Ministry of Health, for screening, yes. For my FIT test, right? Yes. Would it be possible? How would you imagine doing something like that to create awareness with a younger woman? Because by the time we're realizing all this stuff is happening, it's not that it feels too late, but we feel like blindsided. What are your thoughts on how to make that more part of a process? Is that to treat menopause or? To create awareness. I think part of the issue is we don't know it's coming. I think part of the thing is, at 35, I wasn't thinking that it's on my doorstep. So I mean, there's no one size fits all for all women, because we can't tell exactly when a woman is going to, start the journey. And it varies, depending on your family history, depending on your medical history, depending on so many things. So that's why we don't have like a program to say, all women over 40, this is what you need to do, because you don't know. They may not have anything until they're 49, 52, and some start, much earlier than that. Mm-hmm. So you just have to work with women. The important thing is for a woman to feel empowered to inquire about the symptoms she's having from her healthcare professional. And that comes from previous interactions.
You know, so if they feel heard, if they felt heard in the past, then they're more likely to bring up, you know, symptoms that they're having now that don't kind of make sense. And then you can guide them.
I think that there are some questions that the community, you know, we hear in terms of what's normal, what's not normal. Why don't we tackle a few of those questions?
Okay.
The chaos of a period leading up to menopause, can you walk us through what it can look like, the different scenarios?
So it is very, very variable. Some women have, you know, dwindling periods, you know, so maybe prior to the change, they were bleeding for like 5 days in a row, and then it goes to just 1 or 2 days, you know, but it's still regular. Some have regular clockwork period, and then all of a sudden it just stops. Some people have, you know, it's getting farther and farther, so they miss a month, miss 2 months. But some women can have the other extreme, in which case they have 2 periods in a month and a lot of bleeding, much heavier. The other thing is that they could also have other gynecological problems like fibroids, you know, thickening of the lining of the womb, you know, from polyps and things that can cause more bleeding. And all that can mask the picture. So there's so many different, you know, presentations of the period.
So if your period is kind of all over the place, including this twice monthly, is it a good idea to go talk to your doctor?
Definitely.
What about physical exam, you know, versus just talking about it? Because I've seen a lot of virtual health apps pop up, and there's, you know, I still believe there's a component that requires, you know, when is the time to do a physical?
Right. So, yeah, whenever you're having symptoms, the ideal is to have an in-person appointment.
Yeah.
Because it's so easy. You're in a consult, you ask all the questions and you state your concerns. You can get examined. And if it's a polyp and you get a vaginal exam, you can make the diagnosis on the spot. But, you know, if it's virtual, then you order all sorts of tests and you lose time. So the ideal is to have an in-person appointment, but we know that's not always possible.
Right.
So whatever is available is still better to get something.
Something is definitely better, and we're not knocking the virtual because it has been born out of necessity, I would say, right?
Yes.
If 6 million Canadians don't have access to primary caregivers, we're going to see things pop up to try and relieve address that problem. On the issue of polyps and heavy bleeding, is ablation the only option? Can you tell us more about how that's managed? Definitely,
ablation is not the only option. The first thing is to find out why the heavy bleeding is.
Yeah.
And then usually while we're doing that, we're just trying to rule out the nasties, because you have increased risk of uterine cancers that can occur. So you need to have a biopsy to make sure that's not, you know, the issue. But generally, most things are benign. Oh, well, ablation is just when you take away the lining of the inner lining of the womb.
Like, are you scraping it?
No. So you can use heat, you can use laser, you can use chemicals, and it just thins it out and makes it inactive, kind of like dries it out. So that because it's a lining of the womb that constantly grows at every time of the month and then sheds when you have a period. So to try and take away that process, you can, you know, heat it up, you know, thermal ablation. There are several ways, you know, that are available to remove the lining of the womb. There are ways, you know, you can have an IUS, and what's called an intrauterine system, like an IUD that has hormones in it, put in. And you don't have to have the ablation. If you have the IUS put in, it's done in the office. It dries out the lining of the womb, and, you know, periods stop. And lots of women carry that through the whole menopausal. You can carry it up to 10 years.
All right.
And it treats, although it has its own issues as well. You can have irregular spotting, which is more of a nuisance than anything. But that's also an alternative. So ablation is not the only treatment.
Right. And if someone did have an ablation, what does hormone therapy look like for them with respect to vasomotor symptoms and, you know, bothersome symptoms?
The fact that they have ablation only treats the bleeding.
Okay.
So if they're still going to have hot flashes, they're going to still have hot flashes. It doesn't take away the forgetfulness, weight gain, all the other symptoms. So they would still they could have, you know, medication, like the antidepressants we talked about, or clonidine, or they could have hormone therapy in spite of that. But it's just, the ablation just treats the uterus.
Would they need still estrogen combination with progesterone?
To protect the
lining?
Yes,
they would still need
as long as a woman has a uterus, she needs the protection of the uterus with progesterone.
Do you want to just explain that to everyone, the importance of that? Because I do think, again, you talked about the realities versus the ideal. And so I know, I'm not going to name anyone, but I think sometimes people might get forget, like, oh, I'm taking my estrogen. Oh, I have the patch for the estrogen, but the pill, the progesterone is oral, so you have to take it at bedtime. And I'm going to skip a few. Is that a big deal? Why is it important to take our progesterone along with our estrogen?
Yeah, it's very important because as long as you still have a uterus, if you're taking estrogen in any form, it can still get to your uterus, and it will cause activity in your uterus. And if that activity is not checked with progesterone on a regular basis, then you increase your risk of what we call hyperplasia, which can lead to cancer. Which is why we only give estrogen only if you've taken out the uterus,
right,
with a hysterectomy, for example.
Okay. But
as long as a woman has a uterus, you still need to protect the uterus.
I feel there's a lot of women just pushed into what's easy. Let's do the ablation, and I don't know if that's considered easy versus an intrauterine device. But I've met quite a few younger women, who were like, oh yeah, I'm being told to get an ablation. And I'm like, were you given other options? And they're not always given other options. So I'm just really, again, trying to understand that piece. Yeah.
Well, it depends on who they see. I mean, I don't know, gynecologists, we all have different tolerances for, how invasive we want to be. And then people's medical histories are different. If a woman's anemia is such that it's so hard to treat, and you've tried other things, and if ablation is the only thing that will sort it short of taking the uterus out, then that might be her only option. Now, that you wouldn't know unless you were her gynecologist or her,
So it goes back to really making sure that you understand all your options and not be afraid to ask your provider.
Yes. Yeah. What other options are available to me? What can I expect if I take this option? What's the, down the road?
Or what is the why? And I wonder if that's just a measure of the pressure that providers are under in terms of the time constraints. So I feel that we are not always told the why of something.
Yes.
So we're told the what.
But
not the why. And maybe that's where some of that mistrust, or maybe not mistrust, but I'm going to go ask another type of provider, or I'm going to try to figure it out on my own, right? Because we're not always told the why.
Yes.
Yeah.
That's something that we struggle with in every consult, and it's not necessarily linked just only to menopause. Someone comes with cough and cold, and you're like, oh, you'll be fine, it'll be done, it'll be over in 3 to 5 days, just take some Tylenol. And they're like expecting something else, and you don't take the time to explain that this is viral. The antibiotic you're expecting is not going to make any difference. So that's why I am not prescribing it. So, but that takes time. And so oftentimes we don't always have the luxury of that time to explain, but it is very important that patients understand why they're being offered treatment options, and if that's not explained, they should take the time to ask. And I doubt that if you ask a healthcare provider why, that they wouldn't tell you.
I think there's this power dynamic that maybe we've inherited in society. It could be cultural, that the doctor is the knower of all things, and there's a deference, right?
That's a very known phenomenon.
Yeah.
But I feel in my experience that is changing a lot. And we've seen a lot since the pandemic. People spent a lot of time on the internet. And a lot of people have acquired medical degrees off the internet. And so I get questioned a lot. Initially, you're taken aback when it starts, but then now we're all used to it. People come with, I've done this research, so I need you to explain this to me. Or I'm finding that people are taking more ownership and pushing which is a great thing.
I think that's a great thing. Maybe we need to reach some kind of balance in terms of, you are still a trained professional with years of experience, but the ownership piece I think is really key. And that's what I hope that the next generation definitely understands.
Yes.
We talk a lot about estrogen. Aside from protecting the lining of the uterus, the progesterone, keeping it in check, are there benefits to progesterone?
Yeah, so progesterone is one of the hormones produced in the body, and it does help with maintaining the internal milieu of the body. Sleep is one. It helps people sleep. It helps with, the skin. It helps really with keeping the bowels going.
That's a little bonus.
Yeah. So there are definitely extra benefits apart from protection of
to maximize, say, on the sleep, is it fair to say that would it be good to think of taking that at night versus the morning? Does it matter time of day?
It doesn't matter,
no?
But taking it at night is always would be a good thing. I'm not sure of any studies that have shown a difference in efficacy between taking it in the morning and at night.
All right.
But it does make sense because progesterone helps with good sleep.
Dr. Fola, I feel like there are so many more things we could talk about, but for today, if there's 3 things you want us to walk away with, what would those be? Firstly,
if you have any concerns about symptoms that are recurring and are affecting your life, talk to your healthcare provider about them. That would be the first one. The second one would be, don't feel alone. And if you have any questions, ask. Don't feel pushed or pressured or dismissed. If your questions are not answered, ask again at another appointment. And lastly, the menopause journey does not last forever. It can last a while, but it doesn't last forever.
So there's hope.
There's hope.
Thank you so much. And my last question is, what makes you feel beautiful?
What makes me feel beautiful? I would say spending time in worship. I think singing, spending time in worship a lot will probably be the one thing that makes me feel beautiful.
And that's a really beautiful answer, and thank you so much for being here with us today.
Thank you. Thank you for having me.
If you're like me, you probably have your favorite go-to fragrance, but sometimes we just want to change things up, but we don't want to break the bank. That's why I love Victoria's Secret Bare Fragrance Mist. My favorite one is Rose. But if I get a little bored of it, I can switch it up because it's not a huge investment.
Thanks for listening today. This podcast is for entertainment and informational purposes only. The content shared here should not be considered professional medical advice. Always consult with a qualified healthcare provider for personalized medical guidance. We're here to empower and support you, but your health decisions should be made with your own medical team. Until next time, take care and keep thriving.